and some reality as well. So I'm going to talk in general, again, going through the day today, about how we plan, how we obtain consent, how we do the procedure, and how, more importantly, certainly in our country at the moment, how we measure the outcomes of what we've done. You've seen the Noble paper. That's 20 to 30% dissatisfaction rate. I mentioned to you that litigation, in particular missizing and malalignment, is an issue. And the survival rate, which is the one that we use in our joint registry and most joint registries use, well, we all know that the survival rate is only one measure of outcome, and you could have a painful knee replacement for 5-10 years that's terribly functioning, but is still surviving and is therefore classed as a success. And loosening is difficult to determine. So we've gone from this evolutionary ladder of saying to the patient, you need an operation, I'll do it for you tomorrow, to talking a little bit more about the operation with and obtaining written consent. And then we've given information sheets. You probably have in some of your more established departments an information sheet on what happens during a total knee replacement and the rehab involved. And then to some websites, and perhaps the future of obtaining consent for those patients who really want to know is animation and simulation of the operation. And a lot of them go to YouTube anyway. You may want to say, well, actually YouTube's no good, it's not peer reviewed, I'll do my own. And so here's one that some of the scientists at Imperial College have done. It's an iPad application. This is a gallbladder operation that you're seeing here. There's the gallbladder being lifted and the duct being cut. Here is a approach to the forearm. And you can go further with this and show the implant being implanted and the fixation being done. Now, some of the companies already have this, but you could imagine that most of your most common procedures have some animation. The patient clicks on this link and they say, I've watched the video, I understand the procedure. You can then maybe even talk about the risks related to that, and they then click on the link saying, I consent to the procedure. So, we've talked a lot about missizing, malalignment, technical errors in the operation. How can we minimize those errors? The obvious solution 10 years ago was computer-assisted total knee replacement. And it was a huge, huge explosion in technology and uptake, and every company was investing in the computer-assisted systems. However, we haven't had the uptake, and that means one of three things. One, that the procedure using computer-aided assistance is not efficacious. Two, it's too expensive. And three, the surgeons do not like doing it because technically it's difficult or longer. So we know from many studies, including this meta-analysis, that although navigated knee replacement does give you less outliers, so less really poor alignment results, there really are at this moment in time no long-term clinical benefits. So here we are, here are the outliers, here's a paper, there are many of them. The navigated is the blue, much less in the way of outliers compared with the non-navigated. You could argue that that's actually down to surgeon expertise, because most of us who do more than 20 or 40 total knee replacements a year would like to be within the tolerances of between 2 and 3 degrees of malalignment. There's also this problem. You have to have pins, most of them. There are some systems that don't use pins, and you can get periprosthetic pin-tracked fractures. And there's no doubt that computer-assisted does increase the time of the operation. I think it's less than 17.5 minutes now. It's probably down to 10 or 15 minutes in those people who do it regularly, but this is not for the occasional surgeon. So the ideal scenario is we go from the mobile phone that we had in 1985 to our iPhones. Most of us got iPhones or Samsungs. And in order to do that with computer-aided TKR, you need accuracy, efficiency, and a minimization of cost and complication rate. But that's a big ask, and we're not there yet. But perhaps we can move the computer assistance out of the operating theatre, where it's a high-stress, extremely expensive environment, and try to plan the operation better and use our instrumentation related to this. And so we can save time, save resources, and save mental energy, and focus on soft tissue balancing. So we're now into the era of patient-specific instrumentation. But there's a long process. You have to register the case. The patient has to undergo some form of imaging, usually CT. The image then has to be processed by an engineer who's qualified in the process. The surgical plan has to be reviewed by the engineer and the surgeon. The guides need to be manufactured, and then you perform the surgery according to the guides. So here's the system that we've developed at Imperial in conjunction with Matt Ortho. Here is a pre-op plan. This is the amount of bone that you're going to have to resect. That is the prosthesis being morphed onto the pre-op plan, and that will give you the size of the prosthesis. Many studies show that at this moment in time that CT is better in defining the bony landmarks than MRI, although MRI is catching up. MRI technology has improved even since this study back in 2008. So you then have to create the plan. The engineer has to decide where the cuts are based on some pre-programmed programs, and then morph the component onto the program. From that, 3D printers will cut the cutting block for the prosthesis, and this cutting block will only sit on that bone in one way. And so that is the key. If the cutting block can sit in other ways, then you've lost your whole referencing. So the cutting block can be tried on a 3D model pre-operatively. So you can see if the cutting block's fitting, and it's fitting to your pre-op plan before the operation itself. And all of this should mean that you reduce the huge inventory that we have in orthopedic arthroplasty that entails a huge amount of storage, a lot of redundant instruments 90% of the time, but you do need them that 10% when you're in trouble. And we should be able to reduce from many, many trays to this. So even further in the future, can we avoid CT scans? Can we do X-rays and get 3D representations from that? And it may be that CTs, a lot of the CTs do use quite a lot of radiation. Some of them have reduced radiation, but an MRI would be even better because there's no radiation at all. And the aim of all of this is that you have reliable surgery with reduced surgical risk, lower morbidity and rapid recovery, increased productivity because you have pre-op plans, everything is done, and all you're doing is fitting the jigs onto the patient and making your cuts, and then fitting on either a custom-made implant or an implant that you know is the right size. And that increases productivity, reduces surgical time, and reduces sterilization costs. And all of that, particularly in our health service at the moment, which is probably more cash-strapped than some of your insurance companies, cost is a big issue. And our managers will not sanction anything that's only efficacious but without a cost reduction. But, there is a but. We haven't got there yet. This is a whole process, and the more steps that are involved in the process, the more the potential for errors to occur. So you could then amplify an error that occurs in image processing many, many times over before you go to surgical implantation. Now, AJ mentioned robots we do have some robots, and we've done some trials with robots, but robots are very expensive, they involve a lot of space, and at this moment in time at Imperial, we're not using the robots a huge amount. So, you've done the operation. We now have to justify again that our operation is successful. And in the old days, you'd say to the patient, it's a good knee, isn't it? You're pleased, aren't you? We can't do that anymore. One of the best tests that is recommended is, have you forgotten about your knee now? Because it's so good, you don't really recognize it from the other normal knee. And that's a good test, but it's a very binary test. We've then gone down to patient-reported outcome measures, Oxford knee scores, IKDC scores. But the future is this. Now, this is a very crude representation, but you have skin markers on the patient, you have a force plate with a treadmill, and you can measure every movement of the patient with the amount of force that they put on their leg. And one simple presumption is that if the knee is relatively normal, there'll be equal force between the legs. But you can do far more than that. You can assess for varus valgus thrust, hyperextension, abnormalities of gait. And here is a IOACON system with those skin markers on them. And this is a normal walking patient. And you can add in a whole level of complexity here. You can look at sagittal plane kinematics, coronal plane kinematics, and pre-op plan your operation because you think, okay, there's a greater adduction moment here, the MCL is much tighter here, or post-operatively you can say the kinematics has returned to a symmetrical normal gait. That's a successful operation in a patient who's pain-free. Now the real future, someone asked about infection, and as I said, Jay Parvizzi has developed an assay for one of the enzymes that are generated by the bacteria, and the future may well be biosensors. And all that means is that there's something that produces a tangible output in response to a stimulus that it's got. And that could be immunological, it could be mechanical. So at Imperial, we're developing biosensors which can be implanted with the prosthesis, and if the prosthesis is loose, the sensor will tell you that. Another one is, has the cement gone off? Or is the cement loosening? You then have, so those are mechanical biosensors. You can have immunological or chemical biosensors that determine whether a patient has infection or not. So I've just added this in because we were mentioning post-operative infection. This is SPECT-CT, this is positron emission CT, which basically the positrons are taken up in metabolically active tissues. So here's femoral loosening on the left and tibial loosening on the right. What we don't know yet is whether the SPECT-CT will be able to distinguish between infective loosening and non-infective loosening. But that's a very exciting area, because actually, again, it's not high radiation and it's a non-invasive test. So in summary, the future is about increasing the accuracy of the surgery, but without technical challenges or cost. Patient-tailored surgery, different assessment methods of outcome, and biosensors. Thank you very much. Any questions?
One of the downfalls of CT, as far as I understand, is that if you've got, say, a medial compartment OA with normal lateral compartment, it doesn't take into account the thickness of the cartilage on the lateral side. So there's going to be a bit of a mismatch when you put your G on there. It's based on both.
Yes, no, that's true. But then you're taking off the cartilage anyway, aren't you?
Yeah.
But you may fit, yeah.
Any more questions? On Chim?
Chim will also support me by saying all of these modern technologies still ignore the patella.
Agreed, absolutely.
the faculty. You can have the faculty here.
Any questions for any of us, or in general, or anything, we have some time, we can discuss after that, or we'll go and see the bone model, or have a go, we can go there. But we are happy to answer anything. Feel free to ask anybody anything.
Yeah, Dr. Chenna.
Hi.
So if you had to do a knee, if you had to get a knee tomorrow yourself, you come to me.
He's absolutely right. I would choose my surgeon first. Forget all the technology. It's always going to be the case.
You research the most on between CAS, PSI, and this. Which one would you choose? Which one would you hedge your bets on?
At this moment in time?
Yeah, at this moment in time.
At this moment in time, I'd rely on the surgeon. We're not there yet.
No.
PSI.
Obviously, you're going to choose the surgeon.
Yeah.
Surgeon is
Okay.
obvious. But
Then it's going to be
surgeon is giving you an option.
PSI.
PSI.
It'll be PSI.
Yeah, I think the rest are too far to get.
Yeah.
You're still not there.
Treatment of infected knee here.
My treatment?
Treatment of infected
Comes
TTR.
my choice.
Is that a question or is it I got you didn't say knee after class. So that is
Maria, I would like to ask one question. Have you ever done arthrodesis of knee joint in any of your clinics?
yeah. We've done a couple.
One.
How many have we done? 2 or 3? Two of them. One was good. The other was a patient from Afghanistan, this lady. Had a solid time. And but the good thing was that we didn't do it after 4 surgeries. It was remove the implant and do it kind of situation. And the patient this kind of, we gave the option when it got infected that either you can go to this. And it was a situation where you actually had first you did this, then you did second time, third time, then the patellar tendon gets was 20 years ago. It is a proper decision in both instances, okay? Right, I can't afford more, I don't want to go through this, it's enough, just go ahead and choose it. And both were steadily, both were in 2 stages. There was a discussion in the thought, shall we just remove it, even if it is infected, obviously infected, cure it, clean everything, debride, and choose it straight. No, we chose to go the other route. First stage, got it dormant, and then did it. But it's a problem. We used both the external fixator and then we kept on plaster for quite some time. And that was the safest thing which we thought. And in one of them, it came a through arthrosis. We actually, this is that second lady. And she's chosen to use the brace and go along. One did well.
Yeah, same here. I've done 2 and one of them has not united till now. It's almost 10 years.
What's your mode of
It's not in pain, but she's moving around, but it shows that she has still some mobility and you can see elicit the mobility. And that's 10 years back and she's still comfortable.
I also feel
She
that
won't allow any surgery also.
yeah, because she thinks it probably get worse. Because they've had enough. And as we started this morning by saying, that this is a surgery where the patient is more happy, the doctor is more happy than the patient. And so in a complication it perhaps gets even more
I
aggravating.
saw the page. I had a lady. I did a infected total knee. I did a 2-stage. I put an articulating spacer when you come forward.
Yeah.
She came back to me and said, right, now we need to plan the second stage. I said, what second stage? Can you take that out and put on the, oh no, doctor, I'm very happy with that. This is made out of cement. In fact, I walked on this all the time. And she's still got it in 5 years later.
Well, this used to happen with girdle stone very often. Now it started happening. An excision arthroplasty is really not an option in total knee, vis-a-vis total hip. But maybe we haven't done enough and studied it.
And then amputation is another option. You have to talk to patients about. I've only done one in 10 years, 2 or 20. But occasionally you have to do it.
He will process the metal bags, he will train better or which one has more benefits.
All poly was this thing in the morning. But yeah, there was this thing in the morning. All poly. There's no way to prove that all poly is any worse than metal back. But on an better. And but those who are doing all poly and have experience, they say we can get the same result much cheaper. So it's about getting used to one of them and doing them properly.
All poly is on the way back.
I think I've done a study of my patient. I'm doing both, though all polys are very less, almost 10%. These scores are better in all poly, I do not know, and the range of movement is not over.
There's another issue that it also depends the type of patient that you're getting.
Because I have chosen the better patients.
I don't remember a patient coming to me in an auto. And if I tell them that it will be 1/3 the price and you will reach sooner and it is very good and it's not raining, take the auto. No, I want a car.
Don't expect the instrument companies to come and encourage you to use them. They've been very quiet. If anything new comes out, they're not going to, oh John, you must try this new thing, you must put this in. I haven't had enough, you must put these all quality. Also, look, they're about 1/3 of the price.
You ask something about infecting, if you want to localize the question, you actually get answer it. What do you want to know about the infected knee? I mean, it's just infected knee is too big. Just want to know about the yeah, I mean, you want to know that, yeah, an antibiotic loaded spacer has to be put in. Normally, the antibiotics which are adding, the normal one which you get is gentamicin. Usually, if it is sometimes with MRSA or otherwise, you can add the vancomycin or any antibiotic that you are adding. It is normally 1 gram for every 10 grams. So a 40-gram packet should normally have 4 grams of antibiotics, which means about 8 vials of 500 milligrams. There is no point just dusting one vial and saying I put antibiotics. Or you can also have pre-made like Calpol, other antibiotic loaded cements. If you don't want to put these patties or your form like this, you have antibiotic loaded spacers, which are also available in DM by Prostalac. They are about 40,000, 50,000 rupees. They can be put in, they give you motion while you do that. And if you want to go halfway, then you remove the implant which you have just removed, autoclave it, and line it with a thin layer of cement, which you put antibiotic and put it back loosely into the system, not cement it firmly back.
The Prostalac ones, they're the ones that come already made up.
Okay.
The ones I use where I've got the mold and all that, they're much cheaper. And the advantage you can put whatever antibiotic you like. You're not going to keep these, so it doesn't matter about the quality of the cement and weakening the cement. You can put whatever you like. It's just an extension. Do you have desktop sterilizers? What we call little systems. We were not allowed them in the UK. Another good way of trying to get these Prostalacs is to get some old components, wash it, sterilize it, and then put it back in with a new bit of cement, loosely. So you don't bang it in, keep sort of moving it until it's gone off. And it's slightly loose. But then you can close the wound up, and then come back at 6 weeks, 12 weeks, take it out, put the new stuff in. But not polythene. You can't put the polythene in. You remove all the polythene first. It's necessary for the new spacer, polythene spacer.
Yeah. For that matter, if you ever open up a knee for any reason, it's always a good idea to change the space, the polythene. Any
not telling you where you should cut. So you've got the patella tendon and the quadriceps up here. And here you've got the trochanter like that. So what I do is I measure it first of all with a caliper, and they're normally about 25 to 30 millimetres. And I always want to leave at least 15 millimetres left. So on it I will mark 15 millimetres from there. To patella back into position like this. And I bend it to about 20, 30 degrees, something like that. So it's sitting there like that. And then from the side, so it's sitting there at the side like this now. Behind this thing here, so I've got this here, and the patella sitting about here now because it's 20, 35 degrees. I will get a little metal ruler and I'll slip it under there. So it's sitting there and the metal ruler is coming out from there. Now I know that ruler, because it's sitting there, is parallel to the front of the prosthesis like that. And I want to get this cut here parallel to there. I want my button to look like this.
This is where this line will go. There's a line on top of it.
And I want this line parallel to there. Then I know I've got the right cut. So I've marked it along there. I then flex the knee to about 30 degrees. The patella sitting in here like that. My metal ruler is like that. So I'll make sure my saw blade will then go in parallel to my metal ruler. And it will cut across there like that. So I know that my osteotomy there is exactly in the right angle. And the x-rays you'll get will look like this. By the way, I drive an Indian car, a Jaguar. So you want your x-rays to look. You don't want to look like that. Now I thought I was quite good at cutting the patella. And that's when I did with a jig, a side cutting jig. And I thought I'd done a good cut at the operation, but you can see it's not. I mean, it's sitting in the trochlea, but it's angulated. You want it to look like that, post-op, or I took several of these, just patients who walked in one after the other, so I didn't pick them, like that, or like that, or like that. Okay. And if you do this and get used to doing it, all your smile lines will look like that. So that means the patella is tracking perfectly down the middle, and I guarantee you will get less patellofemoral pain and less loss of motion, because either the patella hasn't been cut thick enough or the angle's wrong. Try it and see what you think.
Are you replacing all of them?
I virtually replace, I say yes, nearly all of them. Very rarely do I not replace them. But if you are going to replace them, you've got to do it properly. If you don't think you can do it properly because your jigs are no good, don't replace it, because you'll cause them a problem. Happy with that? The jig should hopefully be made, who knows. We'll mark this one. I would go down, if there's a thin patient, you can feel this, and then you just mark little dots like that, you feel where the bone is, and I'll make a line like this. So I know that is in line with the tibia. I'll then put this on. See what you're cutting will look very similar to what you decided on your pre-op. And if you're not sure, cut too little. You can always cut more. You can't put it back once you cut it, so don't cut too much. Otherwise you'll be left with no PCL and a big space. So you put those pins in. And always check at every stage. If it's hard bone, pre-drill this, it's often useful. Often it's difficult with this. Yeah. So if you do this, one goes, if you go lateral, it will give you a varus cut. So if you're going to move it any way, move it a bit more medial if you're not sure. They're on the side. Yeah, and if you make your cut a little lateral, it probably doesn't matter. You'll always, nearly always, if you miscut the tibia, cut it in varus. Nearly always.
Basically, it's not really required.
People do it differently. Everyone's got a different leg. I like to see it line up with this. Nearly always lines up with the second metatarsal. To be honest. That's no problem.
Tables of foot is always located.
Yeah, well, sometimes you might not. It depends on the shape of the leg. You might find it's too much.
John, as you said, you are towards cutting the tibia in varus. So this should be going which way?
No, I cut. If I'm going to cut, I'll cut it. Tend to go towards valgus. So this should go medially. That'll give you a bit more valgus. You nearly always, if you cut it in error, cut it to varus. Although 3 degrees of varus is anatomic. So what we used to think, oh, my tibia is a little bit varus. I'm quite happy now if it's a little bit varus because it's correct. And that's only been really sort of talked about the last 10 years. It was always 90 degrees, but now it should be 87.
So you take it from the highest point, or you say
The highest point on the unaffected side, yeah. So if you're with a varus deformity, take it from the highest point. Well, not, you don't want to go up into the intercolumnar notch, for instance. But somewhere on the plateau, somewhere, yeah. It's about right. Slides. Look at it. Yeah, it's gone all over. These are very difficult. Yeah.
If I take it more lateral,
You're making a varus cut.
varus cut.
Making a valgus cut. It's all about the
जरा सा फंसा है लेकिन नहीं फंसेगा तो कट नहीं जाएगा
Yeah, exactly. Yeah. So if you've got a valgus deformity, you measure it.
Touch to
If you've got a
the
rheumatoid knee, it might be both.
not be on top
You might not want to cut a full 10 millimeters. You might want to cut maybe only, I'd say, underestimate it a little less, because if you cut too much,
we are
both sides.
talking about medial wear
If you cut
so you have
too
straight
much
it
off,
from
you
the
might be left with a very
unaffected side or
lax
the
knee.
healthy side so
If you
you
cut a little bit, it's too tight,
valgus knee you'll have to
go
take
back
it
and
from the
recut
healthy
it.
side
Ever in doubt,
the difference between a varus and a valgus would be that in a varus you will try to take about 8 mm
it is
of the healthy side.
collapsible. It is collapsible. At what level it must be measured? Whether it is coming down and
No, this you fix now. This is when you are taking this, you are taking a 10 mm cut. When you bring this down to 8, now you are taking 8 mm cut. So if you take it up till say here, so now this will come up, your cut will go down to 2 mm. This jig is for telling you that how much cut you are taking from the healthy side, or the side that you are making.
इस वाले कहाँ गए कौन
Malik, hammer ये जा नहीं रहा इससे.
उसको थोड़ा सा काउंटर देना होगा ना
तो यहाँ पे स्क्वायर देखोगे तो 0 लिखा होगा इसके साथ इंस्ट्रूमेंट को बोलो स्क्वायर बनाओ जो 0 न्यूट्रल है इसका रिमूव
So I've done this, remove this, and then you can now take the saw and take your cut. Different ways is
lifting up
once you have fixed it, like, can you change the angulation of cut like from this distance? Or before
Now we have fixed this upper part. This part is only mobile till the time you have not fixed the pin.
Okay.
So once you have fixed this pin, this is for
एक बार और चेक कर सकते हैं इसका रिमूव कर
Like second top you talk about like 8 millimeter you can from the lateral side.
yeah.
So that can be changed only with the distal one.
No, this is actually I didn't see it. Here's the jig.
ये यहाँ पर से खोलने का है
Yeah.
ये जगह से
This is the one. You see this?
Okay.
This is the one which is marked over here. So this is the one which was telling us whether we are taking 8 mm, 10 mm. So this is increasing or
thickness
decreasing
of
the
the
height.
cuts, not virus valgus, only
So this
thickness
is
of the
only
cut.
for the thickness. That you have already aligned your jig to the
The second one you also mentioned.
between second and third.
ये
Between
कटिंग
second and
करना
third.
सर.
Then you take this. Slowly, slowly. Go and go. Both hands. First you go in first and then press. Yes.
you should always check
that helps. It's always best for beginners. It's always best that you put one on the medial side, one on the lateral side, and one on the posterior side. You should always put it, once you have completed, put in an osteotome and invert it with an osteotome so that your cut becomes symmetrical.
After removing.
Yeah, you can remove. Once you have taken the cut, you can remove this. This comes out. That will come out. Just pull this way. Yeah. This comes out, and you can complete it with an osteotome.
Some people prefer doing it strong only. It gives a
No,
smooth
it's
cut.
लास्ट
You have
में
taken
अगर
the
शॉट
cut with the
डालेंगे
saw.
तो
Okay, that's fine. When you put an osteotome, you just lift this thing that
You have to
cut
lift
out.
it.
Instead of
Not
putting it off with hand and not completing it, but some people, if you are there afraid, then they at the ends they complete it with an osteotome. It's better with a saw. So once this has been done, you see that the cut is fine. You can. This can be measured just for the with vernier calipers, just that you have cut it right. As not all Indians said, everyone said it's always better to take a minimal cut first rather than going in with a 10 or 12 mm initially. So then you can always measure this also. Like initially we started with 8. We started with 8, so you can always measure this. Then if you want to increase the cut, you can again go back, realign your jig, align it again at 2. And now it will be cutting 2 from both the sides. Then again revise your cut. Or tibia can be cut again once you have done the soft tissue balancing and everything. If you are feeling that it's tight in both extension and flexion, so you can again go back to the tibial cut and revise that. See, the extramedullary route, what happens is that it touches the shin on the topmost part, but distally because of the gap in that. But it covers,
Because
proximally
the
it should
thickness
cover
of leg is
this
very
part. It should touch. This jig should be sitting. This jig should be sitting on the topmost part. This part here, distally you will feel that there is about 2 finger breadth difference, because this is the part which is articulating with your ankle. That is, different systems have different things basically for that. Once you have done this and you feel that your cut is fine, now the next thing is sizing of the tibia.
sizing of the
You can see for this, actually the knee should be 90-degree flexed, and then you place it, and then you see. Now again, how do we size it? When you are sizing tibia, like if you are putting a component, first you have a rough idea that whether it's going to be 2.5, 3. The thing should be that it should be covering anteroposteriorly as well as mediolaterally. There should be no overhang. If at any point of time you have to compromise that the size is coming somewhere in between, there should be no anterior overhang. You can go slightly posterior because there you have soft angle you want to cover. There should be no anterior overhang. Otherwise, there would be anterior knee pain. See, what you have to do, अगर आपका साइज जो है वो ऐसा आ रहा है कि 2 और 2.5 के बीच में आ रहा है, या आपको लग रहा है कि साइज मीडियो लैटरल तो बैठ रहा है एंट्रो पोस्टीरियर में मिले वो है, so if you want to use a bigger size like or if you want that the peripheral fit should be there, that a peripheral fit should be there, so it should slightly, you should err on the posterior side as rather than on the anterior side. Similarly,
margin of bone should be there so that there should not be any friction.
This size is fine. But then once you have done this and you have sized this, then instead of fixing this, we can again come back to the sizing that whether this is going to be 2.5 or 2, depending on your female size also. And that can also again give you a guide if you are a little confused between 2 and 2.5. Then you have just seen that okay, 2.5 or 2, both can come over here. Let's go do the femur and then come back and again decide what the size is. Because once when you are putting in the trial implants, it might become that 2.5, it's becoming overstuffed. So then to prevent any further bone cuts or anything, you can just go in with a 2 and you can get with a polyethylene of 8 or 10, whatever the size is coming, instead of overstuffing it and making it too tight. So this is just an arbitrary that where we have fixed it. We are not going to make any cuts or anything right now. Okay. So once this is done, now we come on to the femur. We'll mark it later on. If we mark it right now, see the rotation, I'll come to it once. The rotation, as you said, there are various ways of marking the rotation. But the best way of marking the rotation is that once we have put the trial femoral component, and if you have put the trial tibial component, check your tracking and everything. The tibia automatically takes its shape in that.
With trial.
With trial. The femur is going to be a fix. Once you fix the femur trial component, it doesn't move. but tibia you have got the modularity to move it. So it should be slightly in external rotation, and then when you do your tracking and everything, it automatically falls into place. So then you can mark it with your pottery, and that can be your final point of seating of the implants.
The first cutting of the upper end of the tibia,
Yeah.
and now cutting to the femur.
Now the femur cuts will go, that the distal cut will come the first.
Distal cut.
Distal cut would come first. The distal cut would come first. Then we will go to the anterior and the posterior cuts. Then the notch cuts and the chamfer cuts, because we are using a posterior stylized implant over here.
For the
For this, first of all, you will have to mark the point of intermediate canal entry. Yeah. This is in general about इसमें हो रहा है about 0.72.
So how do you decide this?
You see the PCL attachment coming over here. It's generally about 0.7 mm to 1 centimeter above the PCL insertion.
Anterior to that.
Anterior to that. And there is where you make your entry portal and you go through the intramedullary guiding the So we have to attach this
0.7 millimeter.
0.7 mm to 1 centimeter.
1 centimeter.
White set line, yeah, you can mark the white set line. The white set line is, yeah, it's difficult to mark in this because you don't really have an epicondylar problem. But an epicondylar, trans-epicondylar line, but the most prominent part on the medial epicondyle and the most prominent part on the lateral epicondyle, you try to join them. Okay, that forms your trans-epicondylar line. And the white set line is just through the your trochlear bone. Yeah, it's perpendicular to this. This is the most anatomical, or even say that about 93% of the femur is something like this. The medial condyle is, the posterior part of the medial condyle is at a lower aspect as compared to the lateral condyle.
Yes, sir.
So it's, if you draw this line, it's about 3 degrees.
Yes, sir.
Okay.
Yes, sir.
Now, this 3 degrees external rotation you have to give to the femoral component, because the tibia you are cutting at 90 degrees. Whereas in your articular surface of tibia is in 3 degree varus, but you have cut it at 90 degree perpendicular. So to accommodate for that, you have to external rotate the component. So what you have to do is that you have to cut more of the posterior part of the medial condyle as compared to the lateral condyle. So ये जो टेढ़ी लाइन थी, इसको हमको सीधे इस तरीके से काटना है कि posterior part of medial femoral condyle ज़्यादा कटे, lateral condyle का part कम कटे, और ये पीछे से एक straight बन जाए. So when this becomes straight and your tibial cut is straight, it becomes a rectangular space. Otherwise, in originality, इसके correspond करने में जो है वो tibia की space ये होनी चाहिए. In originality, in original needs like this. It's a rectangle like this, where this angle is not 90.
So how much external rotation?
3 degrees. That is what we mark, 3 degrees of external rotation. Yeah, so that is what we mark. So by white set line and trans-epicondylar axis, this is the 3 degree external rotation of the femoral complex.
So the white line is automatically 3 degree external.
No, white set line is a perpendicular line.
Perpendicular.
Okay, when you place the femoral component through these lines, you mark that 3 degree external rotation. How we do it, that we'll show it to you.
What is the first jig?
The first thing is that you have to put an intermedullary here, this, and you have to enter the intermedullary canal where you have marked it, and you just have to follow the shaft. It will just follow the shaft.
But do you think should pass through isthmus for better intermedullary?
It should just be, it should go through the isthmus, because once you insert the intermedullary rod, it should go through the isthmus part, because otherwise your cheek will not see. But sometimes if you have a say a nail which is coming up to here, you cannot put it. This is where computer assisted helps you better, taking the distal cut at least.
For nailing supracondylar knee, the same thing.
Yeah, this is more or less the same point. So then when you do it, you widen it a little, so that you don't come out of any part of the femur. It was very easy in this opening, but in natural, if you are just going inside wherever you can come out from any cottage. Once when you start it, you just open the medullary canal a little, so that when you are drilling it, it will give you a feel of the medullary canal. So once we have gone this, now they have taken this jig. अरे मुझे इंट्रामेडुलरी रॉड चाहिए. सर लैटरली इसलिए जाना है कि लैटरली हमारा जो एनाटॉमिकल एक्सिस ऑफ द होती है वो 90 डिग्री एंगल में होती है. इसमें हमारी जो है वो लेफ्ट एंड राइट This is left, this is right. Okay. So for general purpose practices, we take about 5 degree valgus whenever we are doing the left or the right. So you have to mark in this. If you are doing a right knee, so you'll have to change this to 5 degree of valgus and lock this. Okay. When you are doing a left knee,
ये left knee.
so you'll have to
go towards left side.
you'll have to go towards left side. Basically, it's about 6 degrees of valgus. The normal mechanical axis of the femur and the mechanical axis of tibia have an angle.
इससे बच जाता है osteophytes होते हैं.
Okay, but because the varus or the
falls up
we generally don't keep it between 5 to 7 days. It depends on surgery to surgery. We generally don't keep it. Some people give it about 7 days. So,
Yes.
three degrees external rotation. हम जब हम anterior posterior cut करेंगे ना, then we'll mark that.
हाँ बोलो पड़ी.
We put it, let it go in, put it over here, and then
मेरे तो ऊपर ही होती है वेंसडे को.
over here the 2 pins. Okay. No particular point in this, because what we are doing over here is we are taking the distal cut. So whether it is right now in this position or it is in this position, it will cut.
आप C-Doc से बोल रहे हो?
But it should generally basically sit on the distal part of the
तो
femur.
मेरी OPD
So we don't have to rotate it. But right now we are not fixing any distal.
Rotation का
Rotation का अभी इसमें रोल नहीं है.
confirm
So once we have fixed this, this cut is basically for extension. Once you have fixed this,
हाँ सर. Extension and this rotation that it takes to the femur is the better move. आप कहाँ पे हो? Mark it and check it.
fix नहीं हुआ है ना, इसलिए नहीं कर रहा.
This is a
And we will do this with this only.
नींद आ रही थी, मैं जरा घूमने आ गया. UK setup is very different. Our setup has a lot of tibia varus, so a lot of foot deformities, a lot of hammertones. So extension mode is better.
एक सेकंड एक
ठीक है, इस बार जाना.
ये पेन लगा दो, ये पेन लगा दो. एक सेकंड रुक जा.
Our cut is not
एक
balanced.
में मुझे मार्क करने दो. अरे मैं मार्क तो कर लूँ दोस्त, कभी तो करना है. Now what I've done over here is कि यहाँ पे marking है. So I've taken about 9 or 10 mm, whatever is the amount of distal cut that you want to take. Generally we take between 9 and 10 mm. Once I have taken this, ये इससे मैं अपना cut जो है वो अलग अलग कर सकता हूँ. That is depending on the type of the femur. This femoral component that we are using, this has a distal femur thickness of about 10 mm. So that is the amount of bone that you have to cut, so that the joint line remains at the same time.
इसमें मेंशन रहता है 10 mm.
That is with the implantation. It might vary with different implantations.
इसमें भी 2 है, 2.5 है.
नहीं ये सबका स्टैंडर्ड है. Whether the size is 2, whether the size is 2.5, whether the size is 3, thickness is the same. Thickness doesn't matter. Now you can take that out. खींच लो, इसे fix करो.
Penetrating comes reflection gap is low. That means this is extension. Touch भी नहीं करेंगे.
खींच लो पूरा पास. खींच लो. पुल.
नहीं कुछ है.
Because the other pin is not.
ये इसका साइज हमको लगा डिफरेंट है. इसका साइज
नहीं वही हैमरिंग के लिए किया, इसलिए तो वो उधर से घुसाया निकलने के लिए.
पूरा सिस्टम बाहर है.
यहाँ पे जो हमारा कट जो है वो सिंपल सा हमारे पे डिपेंडेंट है, तो यहाँ तो हमें 10 mm कट लेने में कोई प्रॉब्लम ही नहीं है। यहाँ तो हम अगर इससे कम 8 mm लेंगे तो हम अपना इम्प्लांट ही मोटा लगा देते हैं जॉइंट लाइन को नीचे, तो यहाँ 10 mm कट लेने में कोई प्रॉब्लम नहीं। वंस वी हैव डन दिस,
यूजुअली टिबिया में 8 mm से इनिशिएट करना है, फीमर में 10 mm।
माइक के पास can go like this. When it's going like this, it's actually cutting less than that. So you can keep a hand over here to stabilize it.
बैक दे दीजिए।
Initially your blade was skiving off.
How much thickness is cutting?
Thickness is coming 10 mm.
There are so many cuts.
That goes in augments of 4 mm. If you have to go, then next cut if you are taking is going more than 4 mm.
The first cut is from the 10 mm.
Yeah, the first one is from 10 mm. You can see this.
This graduation.
Yeah, so next when you move to next, it starts cutting in an augment of 4 mm. Once this is done, now what you have to do is that you have to size the femur. So basically this needs to come out, this needs to come out, and we need to take the femoral side. Now you have to size the femur.
People they suddenly prefer to start off with the femur, then they go to 10.
It's like basically about what you are more used to doing. We have been trained to do more with going to tibia first, so we have got used to a system. It's like again the debate, like posterior stabilized, you can go debating about it at this time. It's just about your convenience. You can go both ways. There is no difference in that. So the basic thing in this is that this thing should be seating. This thing should be seating your posterior part. This is a posterior referencing that we are using, because all our reference points are based on where these two things are going to be based. So it goes like this. This is how we place it, and then you have to see. Ideally that there should be. It is the part where it's really and now you can read the size. Size is coming out to be 4. ये 4 से collaborate कर रहा है. This is the size that is collaborating. अगर देखिए मैं इसको ऊपर ले गया, अगर ये यहाँ कट कर रहा था, it would have been 5. 6 के जो भी आ रहा है. So this is coming to be size 4. So हमारा फीमर जो है वो करीब size 4 आ रहा है. In really it doesn't happen that the knee comes out to be 2 and the femur comes out to be size 4. But ये मॉडल बना हुआ है इसमें जनरली 0.5 साइज का डिफरेंस होता है. 2.53 है. ये this is posterior referencing. This should be really mobile. Other is an anterior referencing in which you take the anterior आप उसको fix करते हो. We don't have a runner with jig right now available. Now at this point of time, with this only, you can mark your 3 degree external. You can do it in medial side पे जो आपकी पिन है. This is the left knee. Okay, so this side is going to be medial. So आपकी जो पिन आएगी वो medial side पे इसमें आपको ऊपर लगेगा. ठीक है. और इधर जो पिन आएगी lateral side पे नीचे लगेगा. This will give you this difference. Are you seeing? This is giving you 3 degrees of extra. You just mark these points and आपकी जो next jig लगेगी anteroposterior cut लेने की वो automatically आपके इन्हीं points पे जाएगी. So it will take cuts according to 3 degrees of external rotation.
ये उधर कर दिया, ये इधर डाउन आ गया.
ये साइज भी ले लिया
दोनों काम.
This is PFC Sigma Johnson & Johnson. Okay. Now you can take this up.
Most of the difference was the thickness of the
अब आपने जो साइज नापा है वो यूनिट साइज 2.5 लेना. We just have to.
ये 3.5 सही था सर. 2.5 ये वाला सही.
नहीं अभी तो ये तो अभी जो हमने 2 निशान बनाए थे इनमें ये हमारी जिग जो है
लेफ्ट राइट के
ये जिग्स जो है यूनिवर्सल होती है, ये लेफ्ट राइट सब होती है। ये तो सिर्फ हमारे पॉइंट्स में, क्योंकि राइट साइड में हमारा ये वाला पॉइंट नीचे हो जाएगा, ये पॉइंट ऊपर हो जाएगा। So it's only medial ठीक है जी।
ये तो इंटीरियर कट के लिए पोस्टीरियर करना चाहिए पहले। ये क्या
नहीं दोनों ही एक ही उससे हो जाएगा।
सब जैसे स्ट्राइकर का सिस्टम आता है उसमें आता है कि 2 एम आता है विंड साइड पे और इसमें जो आता है
पिन भी उसमें चला गया।
उसका जो टेक्नीशियन होता है वो इतना नहीं
इसको काटना है पोस्टीरियर
ये
पहले
हमें ना कट देखने के लिए होता है ना, ये जब इसको लगाया है अभी उस वाले से आज जस्ट शो यू विद दिस वन। This helps us in taking the cut. नंबर वाले उससे जो है ना फिटिंग आता है।
उसमें रहता है पॉइंट
कि हाँ ये पॉइंट जो है कि ये कितना जो है वो हम कट अपना कितना जो है डिस्टल फीमर का ये देखने के लिए होता है।
इसमें भी जाएगा सर,
इस पे भी जाएगा, बट ये उसमें की रिप्लेस में ये दिस इज साइड में जो है करके फर्स्ट टेक द कट आज करते हैं। फर्स्ट टेक द कट व्हिच वन एनी कट ये तो हमने अब एक बार ड्रिल फिक्स कर दी। जनरली एंटीरियर पहले लेते हैं फॉर सेक ऑफ कन्वीनियंस, ऐसा कुछ नहीं है। नाउ वी आर नॉट गोइंग टू मूव दिस। No, anterior cut is only for the seating of your implant.
Drop it and fix the rotation as per the second method. But over a period of time, this method has proven to be more accurate, beneficial, more clinically relevant, or we have found it fast.
Hands over here, na? Try to use the jig like this. So you stabilize it over here also. Or some people can use it also. So this stabilizes this, otherwise this has a tendency to go up and down.
The other rod. You see your whether it goes to the center. Long leg line.
Notching is because plant of size 2.5. Go. ये भी कट दिया. Just go. Let's see. Go further. ये लूज हो जाता है ना. This will get smoothened out.
Alignment preserves the tibial shaft is concerned.
But अगर जिस ये वो रहता है तो नॉटिंग से प्रॉब्लम है. Secondly जो है this cut is not smooth, then the placement of your femoral component is placed, it can push it into.
You are tilting this, then it will.
If notching comes, then you'll have to again go and revise the cut. You'll have to size it again. वो करता ही रहेगा. See, there are different aspects of it. Right now, initially, when the literature came, they were not ready to accept any degree of notching.
Just move.
Now, latest in literature is saying that up to about 3 mm of notching, they don't worry about that. And still, if it's notching, they say that the lateral notching is still better as compared to
3-degree posterior slope which is
still, if it's notching too much, then you have to just again take your cuts. You'll have to just take it a little more anteriorly. You'll have to again revise it. You'll have to take it a little more anteriorly, and then you'll again have to cut back. You'll have to do that.
निकाल के posterior release after cutting
posterior cut
inferior part only. You have to take some more cut from the inferior side.
See, the
Then only
notching basically is first the femur placed right now. You will have to place the tip slightly up, so that your posterior cuts are now going to be more, and then the anterior side
fix we can
notching will be taken care of.
ये posterior खोला
हाँ.
अब इससे मार रहे हैं.
don't do it. So you avoid it, prepare it.
Suppose if you go more posterior, that means we will take more of posterior side. the remaining this gap will be filled up with the cement.
What type of flexion gap? You can't leave flexion as a slab. That is why I'm saying that some amount of not increasing the flexion gap too much. Started exercising. It's all about how you
एमुलेट मत करिए एक बार उसमें जाए तो एमुलेट नहीं करिए स्मूथ जितना हो
हेलो
कोई बात नहीं वो तो वही है कोई मॉडल की वजह से वो है ना
बॉडी का डिफरेंस होता है
बोन भी बहुत टूट गई
राइट मीडियम ऊपर नीचे लेफ्ट मीडियम नीचे
कल का नहीं कल का
ऊपर लेफ्ट हैंड
once the size will
superior cut superior cut
posterior cut this size will come now your notch cut will come now there was a lot of debate about this कि किस कट को लेते हुए जो है वो किस तरीके से प्लेस करना है we had a debate about it that how this needs to be placed so in normal knee basically the thing is that the epicondyle should be visible on both the sides overhang should not be and even if you have to err it should be slightly on the
So sacrificing is not
lateral side as compared to the medial side. But some people have got different ways of doing this. One way of doing this is that, as Dr. Rajiv does it, that he marks once he like this is the position that I'm going to place. And you have to find out whether this position is right or not. You can put in a pottery mark over here.
yes
Then you can remove this.